this technique is not new, but I'm going to highlight what the great Ammar innovated is a pinhole pupilloplasty. I use it in a lot of my cases in my practice. In the challenging where I can't do anything, this would be the best solution. So I'm going to highlight two cases. These are my financial disclosure. So as I said, the credit goes to Ammar and Pereira for this great innovation. I'm going to present two cases. The first case is occlusive pupillae with a topographic astigmatism. And it was a traumatic cataract, neglected, and I thought that this technique will help me a lot in the post-operative results. And the second case, it will be bioptic technique using the toric IOL in cases of high irregular astigmatism or intractable astigmatism with a pinhole pupilloplasty. So the first case, it was a male patient, 55 years old, came to me to restore the vision in the right eye after trauma since many years, ending in occlusive pupillae with just hand motion, and the other is completely normal. On examination, the cornea was clear with a shallow anterior chamber. The retina was normal by ultrasound, and his pentacam revealed high astigmatism. I thought it's not recommended to put a toric eye in these cases because I'm going to do a lot of trauma to the iris to do this case. So as all know that in these cases it's not an easy to open the pupil, but it takes a lot of time. I'm not going to highlight it a lot, but you see as it's thick, and in these cases the iris is also not a normal iris, and a lot of the structure of this iris is completely lost. When you remove a lot of membranes and the pupil, you are going to do more trauma to the occlusal pupillae muscle. And this means that the pupil is not going to restore its function normally. And also another trauma that I made with the dilation of the pupil with the iris hooks, that needs more trauma to the iris tissue. So you need to do a good rexus and put the IOL in the best place, which is very important. But after I remove the iris hooks in these cases, I found that pupil is totally irregular. And this is the trick, that you should specify where the pupil with the Purkinje image. And you do the four group pupilloplasty, which is my technique in the all iris surgery nowadays. It makes the operation very easy and much faster. But the most important that you find your center of the pupil, and you put a scheme where you are going to put your sutures and where you are going to close your iris defects in this iris to reach as small as you can pupil to maintain the central vision using the centration of the Purkinje image, and it's going to overflow the high astigmatism of this patient. And this is what I achieved in this case. It was a dramatically different post-operatively, as I'm going to mention now. So this is how the patient came to me with the vision hand motion, and after many years, and he reached uncorrected visual acuity 2014, despite he has an astigmatism, which I didn't prefer to put toric IOL in these cases because I didn't know how the operation was going to go. Another case is a very interesting case. It's a female Syrian, age 30, came to me for just a refractive correction of her right eye, and the examination of the right eye found that she has an iris globoma congenital, and the other is completely normal. But this eye is normal posterior segment, and the cycloprojection refraction for the patient was +7 sphere with -5 cylinder, and his best corrected visual acuity was 0.4 with +6 -4.5 cylinder. So I asked Pentacam to do a femtoLASIK, which is, I was not happy because of the iris globoma and how glare can achieve the post-operatively. But I did that Pentacam for the patient. I didn't feel happy with this Pentacam. With the astigmatism, it is not symmetrical, the bow tie and the posterior elevation for this patient. So I told the patient that I don't prefer to do refractive surgery for you, but we can do another thing. We can close the globoma to maintain a good vision post-operative. We can use a toric IOL in this case to achieve at least a premier refractive surgery correction. So in these cases, the iris, the capsule usually not an easy to open. So I open it with the cystotome. Very important in these cases to have a good size of the rexus centrally to maintain stability of this toric IOL inside the bag. This is very important. And because you are going to do pupilloplasty, so you need a good centration of the IOL and a good size of the rexus because you are not going to see it again. Very important also to put a CTR in the high toric cases, maintain a good stability and decreases the capsular phimosis post-operatively, which I use most of my cases with the high toric lenses to maintain a little bit stability post-operatively. So after I put my CTR, I mark the patient as normal, and I put my toric IOL, and I finished it irrigation and removing the viscoelastic behind the IOL to maintain a good stability of the IOL. Then I start to close the iris. Very important to see your PKG image. And the first suture of the iris is the best one, and this is the most important. I always say that this is the first step if you want to do a good pupilloplasty. The first suture is the most important because the Purkinje image centrally and closing the iris, maintaining it centrally all the time. And then I close the discoloboma by 3 sutures by the same technique for through pupilloplasty, which is very easy technique. Everyone can reach it easily. And after I close, always look for the Purkinje. So this is how it becomes. It was a 0.4 with +6 and reach it like this post-operatively. So I achieved the best what I want for the patient. So the idea of this technique is performing a pinhole pupilloplasty help filter the stray light from the periphery of the cornea in cases with a higher order corneal abrasion. It also blocks the distorted and unfocused light rays and isolates more focused central and paracentral rays through the central aperture, thereby reducing the abrasion and enhancing the visual acuity and its image quality. It also, the pinhole devices mitigate the impact of what was known for the corneal ablation. The pinhole visual acuity is an indicator of the visual potential of an eye and of corrected vision of the patient can perceive. A lot of contact lenses, corneal inlays, pinhole intraocular lenses help to achieve the pinhole, as Booker said, and the pupilloplasty procedure facilitates the pupil reconstruction and help to achieve an adequate pupil contour size and shape. And my home take message that achieving a pinhole effect can narrowing down the pupil size. The pinhole pupilloplasty significantly improved the visual acuity in patients with higher order corneal ablation by allowing the passage of light through the central pinhole area and reducing the aberrations of the optical system. And also, very important trick, use your Purkinje images helps locate and create a central of the pupil. Thank you for listening, and thank you for being with you all.